Now we move to the second session by Professor Tatiana Milenkovic from Macedonia, talking about sarcopenia in elderly with diabetes. Welcome, Tatiana, to Cairo, and good to see you again.
Thank you so much, respected chairs and dear colleagues. First, I would like to thank Professor Schalthout for kind invitation and also organizing committee, and I'm very happy today to be with you and to share a bit controversial subject on sarcopenia in elderly with diabetes. Okay, now you can see my presentations. So if we start with the definition, what it is the age-related loss in skeletal muscle, and the term is coming out of SARCs between flesh and penia, poverty, so reduce muscle mass. And it is a relatively new term since 1997. It was introduced by Rosenberg, and this indicates the loss of muscle mass during aging. And here you can see on CT scan how it looks, the muscle mass in young and then in older person. So when it happens during the person's life, it is the muscle mass, it's lowering by decade of life. And as you can see there, maybe the greatest lowering in muscle mass starts about 70s, and then it is gradually going down, and it is expressed especially after 85 year of life. So what is the hypothesis about sarcopenia? We know that the muscle mass is progressive, loss is progressive after mid-adulthood. Then usually it is correlated with muscle strength. And of course, low strength, it means, and it is a hallmark of disability. And many disabling conditions are associated with accelerated, even further loss of muscle mass because of inactivity. So this is how it goes during life. And now you can see also on CT images how it is the muscle mass in 30s in the same person, then in 50s, 60s, and after 80 years of life. So there is a significant loss in muscle mass. And if we see it, can see this weightlifter in his 70s, age 63, despite that he is very active even in his 80s, you can notice that there is a significant difference in the muscle mass and probably strength at that age, whenever you are trying to preserve that muscle mass with aging. What are the possible mechanisms of sarcopenia? There are suggested many, maybe the main one, hormones or depletion in sex hormones in both male and female, some neurodegenerative processes, maybe inadequate nutrition in older patients with malabsorption, and of course the physical inactivity at that age is leading to progressive loss of muscle mass. And the final, it might be cachexia, which is often related to elderly person. But there is other manifestation of sarcopenia. This is sarcopenia can go together with obesity, and they have a potential to maximize each other, obesity with a low muscle mass, And at this CT scan, you can see what is the distribution between fat-free mass to muscle mass, which can happen in a lot of people in older age. So this is why important, because in these persons, sarcopenia related to obesity, there will be some relation with insulin resistance. This physical disability and insulin resistance, which can lead to the end to the hypertension, so all cardiometabolic disease, dyslipidemia and diabetes, and finally to increase cardiovascular risk in those persons with sarcopenia. So what about sarcopenia and diabetes? So after the age of 40, sarcopenia is characterized with a loss of muscle mass that is, as I said, progressive, especially up to 70, the progression rate is about 8%, and then after 80, it is 15, then 25% subsequently. So each decade, this loss of muscle mass is even more profound. So the prevalence of sarcopenia varies, depends in which articles you are reading, between 10 and 40%, depending on demographic criteria and what diagnosis it used for, what criteria is used for diagnosis of sarcopenia. And in addition to the previously well-known type 2 diabetes complication, sarcopenia and frailty, in general, these last decades, they are becoming more recognized like a serious risk in patients with diabetes and their cardiovascular risk. So there are many criteria for diagnosis of sarcopenia. Depends on what society are suggesting these criteria. Maybe the latest is from 2021. This is European working group on sarcopenia in older person. And as you can see, there is three criteria that are needed, that we need to diagnose sarcopenia. The first is muscle mass, then muscle strength, and finally muscle function. And how can we judge all these three things? The muscle mass, according to appendicular skeletal muscle index, which should be below 7 kilogram per square meter in men, below 6 in women. Muscle strength, it can be judged by the hand grip, which must be below 27 in men, below 16 in women. And muscle function or performance is measured by walking speed, which should be below 0.8 meters in second to diagnose sarcopenia. So depends of the presence of all these criteria, we can stage the level of severity of sarcopenia. So here we can say that if it is the just low muscle mass but without impact on strength or physical performance, that it is characterized like pre-sarcopenia. If there is a low muscle mass together with low strength or physical performance, it should be a criteria for sarcopenia. And severe one is if we have presence of all these three criteria. It means not just loss in muscle mass, but also strength and performance of these muscles. And then we can see in the upper part of the slide how we can judge what is the decreased strength and poor physical performance. So one very important and very practical thing for everyday practice is determining the SARC-F score for sarcopenia. And this is a very simple way how we can make a very short assessment of our patient, how is their risk for sarcopenia. It is a questionnaire with just 5 questions, and at the end the scoring that we will judge after the asking these questions. We will perform a score, and if this score is from higher than 4, then this person is at a risk of sarcopenia, and it is higher of 6, then it is the higher level of sarcopenia. Why is this important? Because those persons that have a higher F score of sarcopenia, these patients are with higher mortality over next couple of years, and that's why it is important to see in our old elderly persons if they have this higher score for sarcopenia, and we will see further on that we have some ways how to help them to strengthen their muscle mass and to avoid this higher risk for cardiovascular diseases. So what is the prevalence and risk factors of sarcopenia in patients with type 2 diabetes? We can see in this very large meta-analysis that include 28 studies which involved more than 60,000 patients. And here we can see that in these patients with type 2 diabetes, 18% were with sarcopenia. And what were the characteristics of these patients? Patients with older age, male gender, chronic or hyperglycemia or bad control of their diabetes and osteoporosis, they were prone to sarcopenia, and those with lower BMI and metformin in treatment, they were not prone to sarcopenia in this analysis. So high HbA1c, then pre-diabetes and diabetes with complications are associated with increased risk for sarcopenia in this group of patients. What about the cardiovascular risk? That was the discussion this last decade. Is there higher cardiovascular risk in patients with sarcopenia? So it was accused that sarcopenia is correlate with higher cardiovascular risk and higher mortality or earlier mortality in these patients with sarcopenia. And in one study of more than 4,000 patients, older than 70, in addition to finding a high prevalence of sarcopenia, this sarcopenia was associated with worse prognosis, especially cardiovascular risk. So it was associated with increased risk for cardiovascular related mortality, especially in women, not so much in men. While in both women and men, sarcopenia was associated with increased risk for all-cause mortality. And using this American score for cardiovascular risk, all these patients have a higher than 10% risk for cardiovascular mortality if they were diagnosed with sarcopenia. But finally, last year, we actually get a real proof of this concept that sarcopenia is related to cardiovascular risk in patients, and in patients with diabetes even more. This is one study that was made in China in a very, using very huge register of patients. More than 15,000 patients were included in this trial, and it was concluded that sarcopenia were significantly related to higher cardiovascular risk, what was approved of the theory that it is a higher risk. And these findings actually provided the evidence which supported this long debate if sarcopenia was related to cardiovascular risk in patients, especially in general population, but especially in those with diabetes. So now we know that there is a higher higher risk for cardiovascular diseases. So what are the challenges of sarcopenia? Until now, there is no agreed endpoints how we will determine adverse or beneficial outcomes of clinical importance in human intervention studies. And in the absence of widely accepted and clinically meaningful and easily measurable outcomes, little progress can be made in establishing regulatory guidance for development of agents in this area, how to help these people with sarcopenia. So there are some categories of potential intervention that are beneficial in patients with sarcopenia, like physical activity, strength training especially, some nutritional intervention. It was suggested growth hormone and secretagogues, then anabolic steroids, selective androgen receptor modulator, myostatin inhibitors, some biological products like mesenchymal stem cells and placenta-derived stromal cells. These are all more or less in experimental stage. Regarding the drugs that we are using for diabetes, there are some drugs that are with a proven positive effect on development of sarcopenia in patients with diabetes, especially use of insulin, GLP-1 analogs, and DPP-4 inhibitors. Neutral, positive, and negative, you will find the different results in different studies regarding metformin, CGLT2 inhibitors, and thiazolidinediones. And finally, there is a negative effect of glinids and sulfonylurea on person with sarcopenia. So is there any development in this field, any drugs that is promising? It is. There is a myostatin inhibitor with the name of bimagrumab. And there is a second phase of trials with these drugs. The outcome that are measured is static balance, walk speed, and getting out of a chair. These three are very important to judge what is the progression of sarcopenia. This drug is actually monoclonal antibody that blocks activin type 2 receptors and stimulates skeletal muscle growth. And in this phase 2, the results are promising. The patients are gaining significant in muscle mass, and there is a loss of fat mass, and there is some hope that it will be beneficial in patients with overweight and obesity and present sarcopenia, and actually and also type 2 diabetes. So this maybe will be a novel drug that will help these people with sarcopenia and diabetes to have a longer life without so high cardiovascular risk. So there is a lot of questions, more questions than answers in this field of sarcopenia. So will we come to the consensus on a definition that will be uniform for all over the world? As we saw, there is a lot of definition and criteria for sarcopenia. Then will sarcopenia become really widely recognized as an important condition of aging, and with that to enter the territory of clinical medicine? And then will regulatory agency found some functional outcomes that are acceptable in capturing potential benefit of this treatment for sarcopenia? And finally, can some pharmacological intervention be effective in preventing or treating dysfunctional consequences of sarcopenia? And with that, I will thank you for your attention.